Minister, Dr. Foley, other distinguished guests, ladies and gentlemen, thank you very much for the invitation. I was very excited to be invited as the only clinical director to give a presentation today, and hopefully that's a reflection that what cancer is doing is seen as very innovative. I hope to convince you of that. I was given good news and bad news about this presentation. The good news was I get to show off for 10 minutes. The bad news is it's only for 10 minutes. So, I'm just going to describe the Cancer Service and then talk about those 3 projects listed there as 3 examples of many of innovation being performed by the cancer staff. So just to describe the service, we're a service involving 31 departments across 8 facilities. So it's quite a large cancer service and very hard to coordinate, but we've actually got some very good initiatives around the coordination of care across the organisations. This is very sensitive. So we have medical and radiation oncology, a number of surgical disciplines, cancer genetics, haematology and palliative care. Also not in the cancer stream, but relevant stakeholders are other services within other streams such as gastrointestinal cancers, cancer screening, respiratory medicine, imaging and other additional stakeholders. General practitioners is another example. And we have facilities at all the facilities across the local health district, including a very significant community presence. Just to give you an idea, I've purposefully put 2010 figures up because I wanted to make a point in a moment. But in 2010, we saw over 3,000 new cancer patients diagnosed within the local health district and gave tens of thousands of chemotherapy treatments and radiotherapy treatments and consultations. It's a big service. The projected cancer deaths for 2015 is approximately 1,500. And the predictions around new cancer is that there'll be a rise by 2015 of 42% of cancer, but in the southwest Sydney area, it's 63%. Combination of ageing and the low socioeconomic demographic that we're facing. We're facing big numbers of people coming through the doors. And so we expect to see 4,500 patients by 2016, which raises a number of challenges. The reason why I put 2010 figures up is that the numbers of chemotherapy and radiotherapy are going up greater than the incidence of cancer because there is increasing evidence for chemotherapy and radiotherapy in a number of different diseases. So more and more people are being recommended to have chemotherapy or radiotherapy as part of their treatment. So these numbers are going up at a faster rate than the number of new cancers. Now we have lots of strengths. The strengths of the service are the patient numbers. It's great for training. The trainees love coming here. They get to see a lot of clinical material, but they work hard. And people who come and work here know that they're going to work hard. It's a very diverse and challenging population. There are various different clinical and research expertise, and many of the groups have national or international expertise, and I'll highlight a few of them in a moment. We have the Collaboration for Cancer Outcomes Research and Evaluation, or CCOR, which is a health services research group with the Ingham. I'm a member of that group. It has an international reputation about oncology health service research. We have quite significant specialist cancer surgery expertise across a wide range of cancers. We do a lot of cancer research. And we have a vibrant clinical environment, including a lot of locally trained staff. And I take great joy whenever we have a staff specialist position when we employ a former registrar into that position, which we do very regularly. Now, there are many challenges. The rapid increase in cancer incidence is clearly one of them, and looking at new models of care to try and use the resources intelligently is high on my agenda. The non-English speaking background patients present challenges, both cultural and communicative, and so we're always looking at ways of improving that situation. The socio-demographic and education levels of our patients is somewhat lower than average, and so that presents its own challenges with regard to information provision. The smoking incidence, although going down, is still relatively high, particularly in some of the non-English speaking groups, and that's a challenge. There are some service areas within the local health district that we don't have currently that we would like to see here in the next few years, including melanoma, sarcoma and adolescents. And we need to spend a lot of time looking at the models of care around survivorship for one other reason, and that is 65% of patients now survive their cancer. That's incredible survival, but it means that the number of people who are living with a diagnosis of cancer is going up enormously, and that creates some quite significant survivorship issues. And there's a project going on that I'm going to show you. So flagship project number 1 of 3 that we're going to talk about is the Australian MRI LINAC project. This is the flagship project for research in southwestern Sydney by far. It is one of only 3 facilities in the world, and I just want to repeat that, one of 3 facilities in the world doing this research. And typically Australian, we actually went to the facility who did it first and told them they were doing it wrong. We looked at collaboration and came back saying, we can do this better, and I'll show you how in a minute. We've secured $15 million worth of competitive grant funding. Now that highlights to me in a cutting edge type of research that we have impressed the right people to spend money in a high risk project. This is cutting edge. I won't go and acknowledge through all the different funding programs, but it's quite significant, other than to highlight that the NHMRC program grant received one of the highest marks ever awarded for a grant recipient. And the most exciting thing about this project is that there are seven universities involved. So the comic in the middle is just a graphical representation of what this will look like. The 2 big circular things are big magnets. The blue thing is a linear accelerator, and what we're hoping to do is to lay a patient between the 2 magnets, so in an MRI unit, and to give them radiotherapy while we're watching the tumour on the MRI screen. So we'll be able to target the tumour while we're treating the tumour. The reason why it's different to the first one was that the way they've designed the first one is that the linear accelerator can only deliver the beam in one direction. So we've designed this with the double barrel arrangement to do it in 2 different directions, because we want to test both directions, because we believe that they went in the wrong direction. So we're actually hoping to prove that the perpendicular direction is correct. So our vision is to create a unique facility that performs world-class research with a global impact on the science and clinical practice of radiation oncology, to enable real-time cancer imaging and radiation targeting, which will reduce side effects and allow us to increase the dose of radiation delivered successfully to the tumour. We also want to explore the physiology effects of what happens when you actually blast the tumour with radiation, and discover some synergies with combined modality therapy. So the advantages of this project are that we hope to obviously improve patient care by tumour targeting in a better way and reducing side effects even further. It's cutting edge innovation, and I don't apologise for repeating that, and it's the first with this particular configuration. And the chairman of the board mentioned in his speech earlier, attracting intelligent researchers to work together is a major coup, and we have people wanting to come and visit and wanting to come and work for free as part of this project. It reverses the knowledge migration. There was a significant export of medical physics staff around 2000. We are reversing that trend. The biggest challenge though, and I haven't gone into detail, is that the MRI and the LINAC are actually allergic to each other. The MRI is a big magnet. The linear accelerator is made of metal. So you actually have to think through very carefully how you're going to put them together. The other thing is that the magnet bends your radiotherapy beam, a little bit like the way that your speakers bend the TV colour on your television screen. So the challenge is understanding the bend, a little bit like when I grew up I had a snooker table with a bend in it, and I was much better than everybody else at playing snooker because I could get out of a snooker by just negotiating the bend. You've got to understand the bend. I don't intend to go through in great detail, but this is just to highlight the 7 universities involved. Particularly Stanford University in the US are involved in this project. The second project is wellness centres. Wellness centres are cropping up around the world. It's about looking after patients after they've finished their cancer therapy. There are numerous long-term effects, both physical and psychological, associated with having the diagnosis of cancer. And there are many programs identified in that second dot point that have been shown, evidence-based, that they improve the patient outcome. So for example, exercise for patients who are having chemotherapy fatigue improves their ability to get through the chemotherapy. So we intend to build wellness centres and coordinate care in a way that's significantly based around complementary therapy and allied therapy, but in an evidence-based and research-driven way. The aim is to keep people out of hospital and to complete their treatment. It's very multidisciplinary, and there are many good models out there that we're currently going around and visiting. Now, the fantastic news is that we've been given the opportunity of 2 blocks of land, one of them in Liverpool, in Goulburn Street, and one of them in Camden, in Menangle Road. And we've currently got a project going on presently where we're hoping to work up a model of 2 new wellness centres, and we intend to go and fundraise for these wellness centres. So for those consumers interested, let me know and I will put you in contact with that group. The third is the challenge of the number of patients we're going to have to see. There is a greater number of survivors because cancer is not a death sentence, and patients have ongoing expectations that we need to meet, and there are long-term issues that need management, but we have limited specialist resources and we have limited space to see everybody. So this is an internet-based project that we're running with the Centre for Health Informatics at University of New South Wales, which is an online project to empower patients to look after most of their survivorship issues themselves, but with appropriate medical support. So it's a collaborative project, it's interactive, it's a web-based system, but it's basically a patient-held oncology health record. It provides patient and general practice education around survivorship. So for example, a patient with breast cancer can look up the latest treatment for their hot flushes related to the fact that they've had chemotherapy or are taking an anti-hormone therapy. They can look after their bones, they can look after their infertility associated with treatment, all by going onto the website. We're standardising the follow-up of patients. So patients due for a test, they'll get an email reminder that they're due for their mammogram or they're due for their PSA. They'll be able to store their test results online. They'll be able to report their outcomes. They can answer a questionnaire regarding their level of depression or anxiety or their side effects from treatment. One of the more successful parts of this project so far is the patient forum, where patients can talk with each other about some of the common side effects that they're all experiencing and often problem solve for each other. It enables patients to book appointments when they need them in a timely fashion, or we book a patient's appointment if one of their test results flag we need to see them. For example, someone with a PSA rise we would want to see, so we send them an invite. We're looking at developing some webinars for patients for education. We're considering the issue of putting patient letters on there. There are pros and cons of doing that. And if successful, we would like to see this rolled out. So time doesn't give me enough time to run through the program, but this is just 3 snapshots of many I could show you of a very simple web-based design that we have piloted on 50 breast cancer patients. So currently we've designed it only for breast cancer survivors, and we've just finished a pilot study of 50 patients. The bottom line is it's largely successful, we believe, and certainly worth further effort. We want to now work on colorectal cancer as our next big project. And we're currently identifying research funding partners to progress this beyond tumour sites, because what this really needs now is an injection of funds to be able to roll out a series of tumour sites in reasonably quick time. So that project is ongoing, but I think one of the more exciting projects, because I think it will revolutionise the way that we follow up cancer patients. So I'd like to just thank you and thank the invitees for giving me the opportunity to show off for 10 minutes. It was probably 15. A number of these projects, I believe, have excellent long-term potential that help illustrate our achievements. I'm certainly very proud of the achievements of our cancer service, and I thank you very much for your attention.